Welcome to Megabucks Radio. Conversations with successful entrepreneurs, sharing their tips and strategies for success. Real-world ideas that can put megabucks in your bank account. Here's your host, Nina Hirschberger.
Hello, this is Nina Hirschberger, and welcome to today's show. I'm honored to have Dr. Kevin on the show today. I always say this is kind of a little different show when I don't have maybe a business owner, but actually Dr. Kevin is actually a business owner, and we're going to start out chatting about some things that have changed in the medical world, and then we're going to talk specifically about things that have changed in the weight loss part of the medical world. So welcome, Dr. Kevin, to the show.
I'm glad to be on. I'm sure it'll be an interesting time of discussion. Looking forward to it.
Well, I know you've got a long background. I mean, how many years have you been a doctor?
Well, it's getting a little, I'm aging myself here. I'm over 20 years, 22 years now, and the time has just flown by, and I've seen so much change, particularly in weight loss. So over 20 years, yeah. Well,
I mean, and particularly this year, because we're recording this in November of 2020, and we all know what happened in November or in the year of 2020. So I want to start there, Dr. Kevin. So before we got on the show, we talked for just a few minutes, and we, of course, all admitted that we've, dealt with COVID. And you said COVID has actually changed medicine. Let's start there. Tell me what you meant by that.
Well, the best way would be to give you a rather stark illustration of it. I started clinical practice in 1998, finished my medical training in the 90s, went to UAB Medical School, Auburn University undergrad. And at that time, I remember when I finished my medical training that some of the state medical boards, if a physician even advertised on a billboard, or if a doctor advertised in any way, his ethics came into question. Later, I had a doctor who was a friend of mine who called in a prescription for a patient without examining the patient. The patient called, he got the symptoms over the phone, did an interview, and called in a prescription. That doctor was actually called before the Board of Medicine, this was in the early 2000s, and reprimanded for not physically touching the patient, physically doing an exam. Now, when you fast forward that to the 2000s, or the 2020, I should say, with this pandemic, it opened the floodgates of telemedicine. And, I've seen over the last 20 years this evolution of what the practice of medicine is defined as. When I finished my training, the doctor had to physically touch the patient, physically put the stethoscope to the chest. Through the advent of telemedicine, which has really kind of struggled along, telemedicine up through the pandemic was very cumbersome. It was refined or defined by state borders. It was hard for a doctor to do a telemedicine visit outside of the state. And when the pandemic hit, everything changed because obviously there was so much risk to going to a clinic, particularly with older patients, that now it's very acceptable. And it's fascinating. When I do these telemedicine visits with older patients, it's amazing. You see on the video call, they're sitting on their front porch. Their dog is to their right. They've got a glass of tea in their hand, and they just want to chat all afternoon. They're comfortable with that. It's changed what people think of a medical encounter, and therefore opened up all of these medical opportunities for us as physicians and business opportunities to reach patients with much greater spectrum through the advent of telemedicine brought about by the pandemic. Yes.
Well, from a patient standpoint, it's really kind of nice. I mean, if you need to listen to my heart, or if you need to examine something, of course, that you can't see or whatever, that's one thing. But if you want to just, talk about how you're feeling, what's happening, there's a lot of things you can do. And from our standpoint, it's pretty nice not to have to get in the car and drive and sit in the waiting room and wait and then go in and then wait. I mean, it's nice to just have a call. So I personally appreciate it. Which
absolutely.
which brings us around to we started out talking, we're going to be talking about weight loss, telemedicine in the weight loss industry. So tell me, what are you doing there and how did that come about?
Well, I have to tie this in by the first saying that I remember one of the textbooks in medical school leading into this point was written. The textbook of internal medicine was written by a very famous doctor by the name of Tinsley Harrison. It's Harrison's textbook of internal medicine. And one of the quotes he was famous for saying was, if you do a good enough history on a patient, you can diagnose like 96% of the things by history alone before you even get to the physical exam. And so we've seen that very powerful quote that he gave sometime in the 60s or early 70s come to life after this pandemic. And so, concerning weight loss, the evolution that I've seen from my medical training, when I was at UAB, there was profound emphasis placed on the huge health impacts of obesity, particularly in diabetes, other so many things, and we've heard that in the airwaves. 15 years ago, I started treating weight loss in a traditional fashion in my clinic, and did all of the things that every doctor at that time was doing, and sadly that most doctors are still doing now, prescribing the amphetamine-based phentermine or Bontrel or Adipex, which candidly is nothing more than legal speed that doctors prescribe, which amps up someone's activity and energy level, and they lose weight, but it never lasted. Patients would get off that in 6 months and their weight would bounce back. We tried lipotropic injections. We tried B12 injections combined with it. We did all of these reducing carbohydrate diets. We did the Atkins diet, the Okinawan diet, and all these other variations. We prescribed so many steps a day, starting at 5,000 and 10,000 steps. And what was profound to me and what was very sad to me and a constant source of frustration was typically women would come in pairs. Maybe a woman would recruit her friend to come into the weight loss clinic and they would do this program together. One of these ladies would take the medication, would walk the steps, would eat the carbohydrates, do the exact same thing as her friend would do. One would lose weight and the other would not. And I had no explanation for it. And of course, then I would go into lab tests and say, well, we better check your thyroid, or it's genetic. I mean, how many times have you heard your thyroid's off and that's why you can't lose weight, right? So it never turned out. I can't remember a single case that their thyroid was abnormal. We didn't have a good explanation of why some people lost weight and others didn't until the last year or so. So there's been huge advancements, and we can expand upon those points later. But that's the main way that we've seen things evolve over the last 20 years, and particularly this last year. We've had three things to come to face that we're using that are combined with telemedicine are revolutionizing things.
Well, we don't have to wait. Let's do it. Let's get into those three right now. I'm very curious.
The suspense is killing us, right? Okay, well,
yeah.
First, we've learned the overarching theme is that if people can be treated in their homes now, they would prefer that. I think the pandemic changed our whole perspective. Most of the patients that we are treating that want to lose weight are from their mid-40s up or 50s or 60s. The advent of going into a clinic and waiting and going through embarrassing weigh-ins and being in a clinic a lobby full of other people would prefer to avoid that if possible. But up until this past year, we really didn't have a way we could do that in the comfort of someone's home until now. And there are three things that we're doing that have changed things. And they're the three components that were missing before when I told you earlier, those two ladies that came in and one would lose weight and the other. These three areas were missing in weight loss, and this is what we've revolutionized. This is what's going to change the face of medicine. The first thing is that we've learned that when someone is not losing weight they're obese, dieting is not working. The fat cells in their body, in fact, all the cells in their body are running at idle. They're not metabolically active. They're not burning energy. And if you think of all the fat cells in your body as little tiny fat-burning engines, you've probably got billions of those in your system. We've learned that a certain frequency of visible light supercharges energy in the cells of your body. If you remember from high school physics, the colors of the rainbow, the visible spectrum, there was a little mnemonic called Roy G. Biv. It's red, orange, yellow, green, blue, indigo, and violet. Well, that red spectrum, that very narrow red part of a rainbow that you see, we've learned in valid scientific research over and over, rock-solid NIH stacks of studies prove that if you isolate out that red light out of visible light and you deliver it at a higher intensity of that frequency, that when your body's exposed to that, it revs up the energy burning level of fat cells. Not only that, it causes fat cells to open up pores that are embedded in them, and they actually weep the fat out into the lymphatic system. You know, when I first heard that, I was a skeptic. You know, I was trained at UAB to be a scientist, to be skeptical of innovation, to look for proof. And I'll never forget the first article I read in 2011, which validated that very thing, that red light shined on the skin would cause weight loss. Then I read another in 2013 in its infancy. And then since 2013 until the present day, there's a whole stack of valid studies and articles that validate red light therapy. But even then, I'd never used it with patients until my partner, my business partner, a very dear friend of mine, came to me, and we were talking about our wives and bantering and just enjoying a casual conversation. He said, well, listen, you won't believe it, but my wife went to this clinic. She paid $4,000, and all they did was shine this red light on her, and she lost 30 pounds and 13 inches. Of course, what he didn't know is that these bells and whistles started going off in my brain, and I knew exactly what he was talking about. I immediately affirmed with him, oh, wait a minute, you're talking about red light therapy. And as it turns out, that's exactly what was happening. He produced a picture of her holding this model of what 30 pounds would look like. And for the first time, it put a human touch to it for me. It helped me see, man, this is real. The only thing I didn't like about the red light, that story, was the $4,000 price tag. And so we immediately set out and thought, you know, we can beat this. We can do better than $4,000. We can do better than them having to go into a clinic. And so we set out in earnest to find and have built and made a home red light therapy unit just as effective, delivering the same frequency, so that now, during this pandemic or afterwards, someone can literally sit in their home, in the privacy of their home, and they can use this red light machine, which is portable, and shine it even on different spots of their body, do spot reduction. And again, when that red light shines on cells, body cells, it revs up their metabolic burn and literally melts the fat away. Does that make sense to you?
It does. So yeah, there's questions going around in my mind. First of all, it sounds like this is almost a replacement for that those pills that which you said was trying to speed up their metabolism. So this is kind of doing a speeding kind of thing. Am I right on that?
Well, that's exactly right. Without, it always bothered me before to prescribe those amphetamines. Now, again, most people that have gone to a diet clinic, well, they may have known it by different names, but it was either Adipex or Bontrel or Phentermine, and I'm amazed at the doctors that still write that medicine. But yes, it never lasted because it just amped up their metabolic rate in a different way. It caused them to be hyperactive, and as soon as they stopped, this is different. The red light replaces those amphetamine pills, and it works at a cellular level so that it lasts longer, and it's addressing the problem at a cell per cell level. So that's exactly right. Much more precise medicine. We've never had it before.
Well, here's another question. So I'm thinking, if somebody wants to lose 30 pounds, they're not necessarily wanting to lose 30 pounds just in one location. So do they have to put this red light? Well, I should let you explain, but 10 minutes on one side and 10 minutes on another side, and is it a long process?
Not at all. They can simply do this. They can incorporate this into their daily routine. 10, 15, 20 minutes. Obviously, the longer, if you do a 30-minute session daily, you're going to have results that'll work quicker. If you set the machine a little further away from your body, it'll expose more areas. Some people just want to lose weight around their tummy. They want to focus on that first. And so we're able to do that with the size of the machine and with the portability in the home environment. That's right.
Okay. Well, you said there was 3. So the first one is the red light therapy. So what's number 2?
Yeah, well, 1 down and 2 to go. And, the trifecta here that I never had before, that's amazing. Number 2 is the signals that your stomach send back to your brain when you're full. When you go to a restaurant and you eat a big steak and a big meal, it stretches these bands in your stomach, and those bands cause the release of peptides from your intestines, particularly called GLP-1. There's a specific peptide that's released when you're full called GLP-1, which stands for glucagon-like peptide 1. Now, what's interesting is when gastric bypass surgery came out, as a physician, I was very excited about gastric bypass. It makes logical sense that if you remove part of someone's stomach in this costly, risky surgery, that because it's a smaller pouch, that they'll get full sooner. And it sounded like simple science. But the more we did research on gastric bypass, particularly the old Rowan Y gastric bypass and banding procedures, we learned that for some reason, and we really don't know why, people lose weight after gastric bypass because the body increases the amount of GLP that's released. This GLP-1 magic peptide that goes to your brain and says, wait, stop eating, I'm full, I don't want anything else. Makes you feel full, right? So we've learned that after gastric bypass, the reason those people lose weight is that their GLP-1 is secreted at tenfold what it was before. Now, I'm not just speculating about this. There are scientific articles. There's an NIH scientific article published in 2017 that clearly states GLP-1 is secreted at 10 times the normal rate after gastric bypass surgery. So, wow, can't you see it? Can you imagine what would happen if we could just simply bottle GLP-1 and give it to you? Why go through the surgery? Why go through the risk? Why go through the $40,000 or $50,000 expense of that gastric bypass and all the dangers if we could just give you the same peptide that the gastric bypass accelerates? That's exactly what we've done. And so we have bottled the GLP-1 peptide. We are working and partnered together with a really incredible pharmacy that is headed up by a biochemist, by a network of pharmacists. I've been to the pharmacy. We've sat around the table. We've worked on the GLP-1 delivery system and the other medicine that we'll talk about in a moment. But the GLP-1 now is in a liquid. We put it in a small applicator with a hair-fine injector. Literally, you can barely feel it. It goes under the skin into the tummy in the little fat layer, and you do that in the morning. And it does this, and you get that same sense of feeling that people that have had a gastric bypass and lost 40, 50, 60 pounds gets. So GLP-1 delivered in a liquid form is magic bullet number 2. Does that make sense?
Yeah, it does. So I assume that whatever that magical GLP-1 is not harmful like it was those pills, the amphetamine-type pills that you would prescribe.
That's exactly right. Amphetamines are not a naturally occurring body substance. They're synthetic. They're They are people abuse them on the street. It's old-timey medicine. This peptide is actually a naturally occurring substance. Peptides are a new emerging class of medications that really are going to revolutionize medicine, in my opinion, not only in weight loss, but other areas as well, because the peptide is naturally occurring. We're all born with GLP-1. You can find GLP-1 in a 5-year-old or an 18-year-old. It's just that with obesity, that GLP-1 amped up can help lose weight. So it's naturally occurring. That's correct.
Okay. Well, ultimately, I'm gonna want you to tell me how this all works together. But let's go on to number 3. What's number 3?
Well, number 3, the icing on the cake is there's an area in your brain called the hypothalamus. And the hypothalamus is responsible for impulse control. We all do things impulsively. I certainly have been accused of I'm impulsive to some degree. We all are. The hypothalamus controls specifically the two areas it's known for the most are sexual impulse and eating impulses. So there's an amazing, once again, peptide. There's an amazing naturally occurring substance in the hypothalamus called oxytocin. And the more and when oxytocin is released, it sends a signal to your hypothalamus that it removes the impulse to eat. A lot of people are impulse eaters. They go through the line at the grocery store and they see a bag of M&Ms and they bag them and they eat them impulsively, or they eat for stress, or they'll eat a big meal. And so oxytocin shuts that impulse to eat down. It removes the reward of eating away. And so, we thought, wouldn't it be amazing if we could deliver oxytocin to our patients? Now, the way that oxytocin is delivered is 30 minutes before a meal. They take a little tab, that's a little melt tab, and they pop it under their tongue, and that is dissolved in their mouth. It goes directly into the bloodstream. Now, we did that for a reason. We don't want to give a pill because a pill goes into the stomach and has to compete with food. It has to be absorbed at different rates, and we see variability. But by popping that under the tongue, much like heart patients use nitroglycerin, for example, there are other medicines that are used under the tongue. It's a quick melt tab, gets directly in their bloodstream, and so as they're walking into the restaurant, they take that oxytocin, and as it turns out, when they have that impulse to overeat at that big meal, it will be blunted because of the oxytocin. So that's step number 3. Yep.
Well, it sounds like the GLP-1, if I understand it right, the injection that you get in the stomach in the morning, takes kind of your hunger away, or goes up into the hunger. But then because it's impulse, because we have a habit of eating, what you're saying is this under the tongue tablet even helps take that impulse away. Am I getting it?
That's exactly right. There are some people that eat. I've been guilty of this. I think everyone has. I found myself grabbing a bag of potato chips or grabbing something to eat. And when I really stopped to think about it, I really wasn't hungry. I was doing it because I was bored. I was doing it impulsively because of someone else next to me was eating potato chips or whatever it was. And so that's exactly right. We wanted to have a backup modality to the GLP. We wanted to approach the hunger and obesity point from more than just one angle. And so you can see when you stitch all these together, all 3 of these points together, if you work this into your routine where sometime during the day, in the morning or in the evening, you use the red light to rev up the energy burn in your fat cells. When you wake up in the morning, you use a little bit of GLP to kind of get the day started, and that GLP, you have this sense of fullness. You'll enjoy your breakfast, you'll enjoy your meals, but you're not going to overeat. The most profound evidence I see is that every doctor I know, without exception, that is prescribing GLP-1 is using GLP-1. They believe in it. They see it. They've seen the results. They've seen the satiety. Many of them, when we're together, we'll will say GLP-1 is like a liquid gastric bypass. You can't out-eat GLP-1 is one of the things we say. Exenatide is the other name that we use of our medication, but they're all GLP-1. And then finally, you take that oxytocin, you have that with you, and you take that before the meal to take that impulse eating away. Finally, for the first time, now those two ladies that went to a weight loss clinic and one lost weight and the other one didn't, those are the three reasons. In our estimation, when you take those three components head on and you control metabolic burn at the fat cell level, the positive feedback from GLP-1 in the stomach and the oxytocin feedback to the hypothalamus, it's the kind of weight loss that I've waited to see my entire career. And in my view, no, please go ahead.
So then you added into the pandemic telemedicine, so it can all be done in the privacy and the comfort of your own home.
That's exactly right.
Without having to go to a clinic is what you're saying.
That's exactly right. We can simply do the short physician interview over the internet. We've got the side effect and risk profiles are so narrow, so limited. There are really only two major ones. With oxytocin, a pregnant female can't take oxytocin because it could induce premature labor. And if someone has had thyroid cancer, they recommend not taking GLP-1. And so really, thyroid cancer or a pregnant female are the only indication. Usually there are multiple indications. We know there's nothing that we know of with red light therapy that would prohibit a patient starting that. So we can do that in the privacy of their home. We can do the interview electronically again. We can send their medicines directly to them. They don't have to weigh in. They can do it themselves. And the pandemic has delivered that to us. I guess there's some good that comes out of bad, I guess you could say.
Well, there always is, and that's what you have to look for. I want to talk about the group dynamics. I mean, first of all, let's say somebody has to lose 30 pounds. So that's an overweight person, but it's not morbidly obese. How long? I mean, is this, over a year? I mean, how long does it take to do something like that?
Well, truly, it does vary. I can tell you yesterday, for example, I saw a patient that I started on GLP-1 4 weeks ago. This patient lost 18 pounds in 4 weeks. I've seen others that, let's see, the one I saw before that, after the first 4 weeks, lost 7. I've seen more. A lot of it depends on how much, if the obesity marker is greater, the more you weigh, the more rapid you're going to lose weight on the front end. And so it's really hard to pin that down with some, I haven't had a patient that didn't see any sort of weight loss the first month, but it does vary. I've had as little as 3 or 4 pounds all the way up to, from 16 to 20 pounds the first month. I've seen the most weight I've seen lost was around between 65 and 70 pounds from this combination. I've never seen that before, never in my career. And so it depends it's not going to happen in a month, but from 3 to 6 months, you're going to see significant changes.
Well, and you don't want it to happen all in a month anyway. I mean, slower. Now, once you've gotten down to the weight, of course, we've all lost weight and then gained more than Lynn lost, and then you gained even more. I mean, how does this reset anything so that it kind of stays off?
Well, the thing is, you can continue. GLP-1 and oxytocin, again, are naturally occurring substances that are in your body. And we recommend that patients keep taking those. And, of course, keep using red light therapy as a maintenance program. You have to still said and done, you want to modify your diet toward more protein and less carbohydrate. And you do want to get a minimum of 5,000 steps a day with an ideal 10,000 step a day goal. Amish farmers, for example, walk 20,000 steps, and I've never seen an obese Amish farmer, to my knowledge, because they're walking behind those, they're plowing in those fields, and there was a study that demonstrated they walk 20,000 steps a day. The typical person walks 3,000 steps a day. in a office setting with on your smartphone or a little pedometer, you can easily clock 5,000 steps a day, walk 15 or 20 minutes casual and get 10,000. You want to do that. Those are good, healthy lifestyle changes. But I'm here to tell you, you can cut out all the carbohydrates you want. You can walk all the steps you want. But if one of these three areas that we've addressed are out of sync, you're not going to lose weight like you should. So I recommend continued maintenance therapy with the red light, with the GLP-1 exenatide, and with the oxytocin. They're naturally occurring. They're not going to hurt you.
Well, it makes me think about a bowling alley. And if you've ever been to one, they can put these bumpers up on the side. And so, on one side could be the GLP-1, on the other side the Oxycontin, or not Oxycontin, but
oxytocin, yeah.
Yeah, oxytocin. So you're not going to be guaranteed a strike, but you're never going to go back into that gutter by staying in that kind of stuff.
You won't, and it modifies it over time. You develop a habit, and it modifies your basic eating habits, the quantities that you're eating at meals, etc. So there are some lifelong permanent changes, and those bumpers, I haven't thought of that, but it's a great illustration.
Well, Dr. Kevin, this is so fascinating, and who would have thought during the middle of a pandemic it would have been the perfect storm to have pulled all this together. So what is your biggest objection, do you think? So if somebody hears this, think, oh, yeah, right. What do you say to, what do they say?
Well, people have tried. There have been so many things through the years. These people, you can't blame them. They've ordered pre-prepared meals off the television. They've gone to clinics. They've tried everything they've ordered out the back of magazines, et cetera, et cetera. The greatest barrier, I think, is skepticism. The same skepticism I had with red light therapy or with GLP-1 or with oxytocin. The difference with this is there's actual scientific research that you can look up and read yourself that we have embedded on our website that you can review and learn yourself to overcome that skepticism.
And, okay. So, the elephant in the room was how much?
Yes. The amount will be, it depends on which one they qualify for, but I can tell you that it is a fraction of what they would pay. It's nowhere near $4,000. It depends on which one of those components they use. It's a fraction of that. And they will refill those medicines as they need to. But all of this is for a third or less of what the clinics that you go to pay for.
So it sounds like time-wise through the day, so the red light therapy is anywhere from 10 to 20 minutes, and of course, giving a shot in your stomach and putting some tabs under, that's nothing. So the very most, maybe 20 minutes a day, and plus your 5,000 to 10,000 steps, which you should be doing anyway. Is that right?
That's exactly right. And when you eat a meal, in general, we all should be doing it. In general, lean toward the proteins and stay away. If you have a steak and a baked potato, lean toward the steak. Enjoy a bite or two of that baked potato, but don't eat the entire baked potato. The carbohydrates are what get people in trouble, usually. So lean toward proteins, lean away from the carbohydrates. And in general, if you, when you look at servings that are on your plate, if you ball up your hand and make a fist, that's a serving size. Make sure that and that's a generous serving size. Now, the great thing is with GLP-1 and oxytocin, that's all the serving size you're going to want, if that. And it'll help shape those habits as you take these medications to be eating appropriate serving size, being active and walking and exercising, and just eating the appropriate foods, leaning toward protein and away from carbohydrates. That's right.
Well, Dr. Kevin, I'm looking at the time, and we are out of it. But if somebody really wants to know more about this, where can they go? Where can they find you?
Well, the best thing, and we're looking for marketing partners. We're looking to grow this and expand this. We've got a new, powerful telemedicine platform that we are looking for folks to partner with us. Take this number down, 1-800-664-7640. And we can tell you all that you need to know and point you in the right direction. And we'd be happy to discuss that further with you.
Now, that's partnering, but what if they want to actually start on the whole weight loss? Maybe they don't want to, partner with you, but maybe they want to do the weight loss. Is that possible?
Yes, absolutely. And the same number, use the same number. We have we have a way that we can distribute that, and we'll get them connected with the physician for a pass, just like you would call a clinic to set up an appointment. Call that number, 1-800-664-7640, and we can get you plugged in with the physician. We can evaluate what would help, exactly what to prescribe, and we'll get you on your way.
Well, thank you so much. This was a fascinating discussion, so I am honored that you joined me. So this is Nina Hirschberger signing off and saying, check it out. Call 1-800-664-7640. And until next time, be sure to make it a great day.
Thank you for listening to Megabucks Radio with Nina Hirschberger. To learn more about the resources mentioned on today's show or to listen to past episodes, visit megabucksradio.com.